So we are thrilled to have Dr. Christina Escobar here today. Dr. Escobar is a urogynecologist who practices at NYU Langone, and she has an extensive history in obstetrics and GYN. Thank you so much, Dr. Escobar. We are so lucky to have you join us today. Thank you.
Of course, thank you guys for having me. I really appreciate talking to you about this because it's something that often women get told is normal or just a normal part of aging. And hopefully one of the big takeaways that I can give everybody today is that this is, first of all, it's not normal and it's something that is easily treatable. So hopefully that's something.
Affiliate Memphis plans to release video this evening of Nichols.
A little bit about what we're going to be talking about today. We're going to be covering lots of ground, but the real meat of what we're going to be talking about today is how to treat stress incontinence. Because I think as patients and people experiencing this type of leakage, that's what you want to know is how do I fix this? How do I take care of this? How do I go back to living my life? And like I said, the very first most important thing is that you're not alone. Many women have this condition. And I think one of the sort of downsides of this condition is many don't talk about it. And it's important for us to talk about what incontinence is not. It's not normal, and it's not something you have to live with, despite even sometimes being told by doctors that it's normal and it's something that you should live with. And I've even heard people say, you know, I've been told by my primary care doctor that it's a badge of honor for all the children that I've had to have this leakage. And that's hopefully a myth that we'll try to debunk today. Incontinence or leakage of urine is actually pretty complex, and there's many different types of leakage of urine, but if you're going to try to distill it down to the two main types of leakage of urine, you have stress incontinence, which is this picture here. I don't know if you can see my pointer, but these women here are running. And so stress incontinence happens when you cough or laugh or sneeze or do any exercise, anything that's going to increase your abdominal pressure, anything that you're going to Valsalva or strain or bear down, and then you leak right after, that's all stress incontinence. The second picture here is meant to represent a different type of incontinence, which is something called overactive bladder. It's when you get the urge to urinate, you don't quite make it to the bathroom, you don't quite make it to the toilet. It's that I put the key in the door, I'm ready to walk into my house, and all of a sudden, oops, I get an urge to urinate and I don't make it there. Those two types of leakage are very, very different. And so for the purposes of this talk, we're just going to be talking about stress incontinence, which is the leakage of urine when you cough, laugh, sneeze, run, lift weights, go to yoga or Pilates. And we're going to focus on that type of leakage, but I'm certainly happy to answer questions about the other type of leakage. It's just a very different type and we treat it a very different way.
Dr. Escobar, I'm going to interrupt you. I got a message that the audio is a little low.
Oh, yeah.
Muddled. I'm able to hear you, but
okay.
I'm wondering if maybe if you move a little bit closer, that might be better.
Sure. Let me just adjust my camera and let me know if this gets any better here. I'll adjust my computer and my camera here. Is that any better?
I think that's okay for me. I'm sure I'll hear if it's not.
Okay, please let me know if it's not, and I'm also very happy to speak up.
Thank you.
So, like we said, stress incontinence is the leakage of urine. It occurs with any increase in your abdominal pressure, whether that be working out, running, sneezing, coughing, or laughing. And this affects up to 35% of women. That's a lot of women. And so if you think about that, that's 1/3 of the women on this call. That's 1/3 of the women who are out there in the world. And it's something, if it really affects that many women, it's something that we should be talking about more. And it occurs because there's a loss of resistance to the outflow of urine. So the urine, as it comes out the urinary tube, really should be stopped by the ligaments in the urinary tube and the tissue of the urinary tube itself. But often with age, with childbearing, with chronic cough or constipation, the ligaments and the muscles that hold the urinary tube closed and together, they become weakened with time. And also the tissue in the urinary tube or the urethra can become weak over time, and that can stop to be closed and it can open a little bit. And so you see this picture here, you see a normal bladder, the urethra, the urinary tube is closed. When you have stress incontinence, here the urethra urinary tube can be weakened, become open, and any increased pressure from the abdomen can cause loss of urine. Just looking in the chat. Okay, I'm not sure because I'm not able to. Okay, great, perfect. All right. So how do we treat this type of leakage, and what are our options that are out there? And so the next bulk of the presentation is really going to help us talk about treatment options and make sure you guys understand what's out there and available. So as a doctor, I always rely on our governing bodies to really, when I present information to patients, I want to make sure I'm presenting you guys with the most up-to-date information that's sort of approved by the, governing bodies of doctors. And so the American Urologic Association, also known as the AUA, published guidelines not too long ago that talked about how we should approach treating this in patients. And they really felt that patients should be counseled regarding the surgical and non-surgical options, including the risks and benefits of both for treating stress incontinence. And really, if you're going to decide to treat this, the choice of treatment should be made as a collaborative effort between the surgeon and the patient, and really should consider patient preferences as well as the surgeon's experience and judgment. And so when I counsel my patients, when I look to treat patients, that's exactly how I approach it. It's a shared decision between doctor and patient. So here are the guidelines, and I thought I'd put these up for you guys to see, but there are as many non-surgical options to treat this as there are surgical, and we'll really spend the next couple, probably 30 minutes reviewing sort of what these options are and how they can help. So the very first thing when I talk to people, I really start from conservative to more invasive. So we're going to start with the conservative stuff and review the conservative options and what you can do even before you see a doctor. There was a big study that was published in the New England Journal of Medicine that sort of changed the way we as physicians looked at conservative management. And this study, called the PRIDE trial, took a look at women who were obese or overweight, who had BMIs of 30 or greater. And it categorized some women to do a weight loss trial and some women just to get information about stress incontinence, to teach them about what it was and what things they could do to prevent it. And it actually found that those who did the structured weight loss program, they lost about 8% of their body weight, which is not a lot, but it led to 60% reduction in their symptoms of stress incontinence. So I often tell people, if you're interested in weight loss, if you're on a weight loss journey to begin with, simply just losing 8% of your total body weight, which isn't a large amount, can reduce your stress incontinence by about 60%. It's very low risk. It's great for your overall health. The problem with weight loss is it's easier said than done, right? It's very, very hard, especially women as we age, our metabolism is different. And so I partner very frequently with nutritionists, with medical weight loss specialists and surgical weight loss specialists who can help a woman who's ready to lose some weight and interested in losing some weight in their weight loss journey so that they can see this improvement in their stress incontinence. So it's something that's really supported by the data. It's not something that I discount, but I do tell people it's quite hard to do on your own. So if you're interested in it, I always have them, help them seek help in losing weight. So that's something important to just note. Everyone knows these, and I think probably every woman at some point, either herself or a friend or a family member, has mentioned the word Kegel exercises. So we're going to talk a little bit about Kegel exercises now, what they are, and what technology can do to help us with them. So in today's day and age, there's no need for a doctor to walk into a room and say, you need to do Kegel exercises, not explain them and walk out. We have so much more that we can offer patients. We have so much more in depth that we can go. And I like to think of pelvic floor muscle exercises or Kegel exercises. Really, there's many different versions of them. So you can do Kegel exercises just on your own, and I'm going to take some time to explain how you would do those, or you could do them with a physical therapist. There are biofeedback devices. Biofeedback devices are small devices that you can insert into the vagina, and you squeeze the muscles around them, and it can tell you how strong you're squeezing and how long you're squeezing. There are vaginal weighted cones, which I'll show you pictures of and we'll review. And then there's mobile technology. With the advent of the, Android, iPhone, all these application-based phones, there's a lot of mobile technology that can help a patient with this. So pelvic muscle exercises or Kegel exercises are really well supported by clinical data. There are 6 well done, very good quality clinical studies that support the efficacy of these exercises over not doing anything for stress incontinence. but how do you do them? And you can see even all of the different organizations of doctors don't really agree on how you do them. If you look at this table here is a table of 1, 2, 3, 4, 5, 6 major organizations, medical organizations, and all of the descriptions on how to do Kegel exercises are very different. So you can see how, from a patient standpoint, this might be very, very confusing. And not only are the descriptions very different, but the regimens are very different. These are, again, the same 6 organizations, and they all give a different regimen for how often and how many of these exercises you should do. So I think patients get really confused when someone looks at them and says, oh, do Kegel exercises. Even if you were to look up how to do them online, it gets very confusing. So I try to simplify it. I try to boil it down to the things I think are practical and easy for a woman to do. And so how I describe it is very similar to how the American Urogynecologic Association describes it. I ask patients to put a finger inside the vagina and squeeze their muscles around that finger until they feel pressure. There are some women who, for understandable reasons, may feel uncomfortable putting a finger inside their vagina. So I say, pretend to sit on a marble and pick it up with your vagina, and that will activate and engage those same muscles. The timing and the frequency, I really, again, stick with the American Urogynecologic Society when I say I think you should do them 7 days a week, 3 times a day, and I say to pair it with meals, breakfast, lunch, and dinner. It makes it easy to remember. And I ask them to do 13 contractions, 3 for 3 seconds, 10 for 5 seconds. And that's the extent of the regimen when you're doing Kegel exercises. And really, this is not something I let patients go on indefinitely doing. I say, let's try this regimen. Let's try this sort of prescribed exercises for 3 months. But if you're not getting improvement after 3 months, we should move on. And I think that's really important. I see women all the time come into my office and they say, I've been doing Kegels for 7 years. Well, really, after the first 3 months, if they didn't work, then they're probably not going to work from that on out. So it's really important once you try this, if it doesn't work for you, we should keep moving on. So to go to physical therapy or not, so I have a picture of J-Lo here because I think it's, I think it's really interesting to think about how our celebrities really have trainers for everything. They have a nutritionist, they have a body trainer, they have someone who's an expert in health and mental health. And I think our patients should avail of the same thing. So if there's someone who can help you do these exercises and insurance is going to cover it for you and you've got the time to do it, I always think that you're going to get a bigger benefit from working with someone. They'll help you be more accountable. They'll help you identify the right muscles. And so I'm a big proponent of physical therapy. It must be, with some caveats, now it must be a physical therapist who specializes in the pelvic floor. They're actually not included in every physical therapy practice. So the same person who does your PT for your knees is definitely, or most often, is different from the person who does physical therapy for your bladder. It should be in a convenient location. If this is something you're going to do once a week or a couple times a week, then it should be easy for you to get to, covered by your insurance. They should have a flexible schedule that works with your work schedule or your life schedule. And I really stress this, that trust is very important. I see a lot of women who come into my office and they say, I did PT for 3 months, but I really did not vibe with my physical therapist. I didn't like the place that I was going to. I felt exposed. And I always encourage them, if they wanted to see if they can find, we have a list of people that I usually refer to. I say, try someone else, try someone that you develop a trust and a bond and you have confidence with, because it really makes a difference when it comes to your therapy.
A lot of mental health professionals, because she was just that love. The students were.
So biofeedback is one of our new technologies that can help with Kegel exercises. So here you'll see a picture of the LV. It's probably the most marketed biofeedback device out there for women. This little sort of turquoise egg you insert in the vagina, you have an app on your phone, and it will walk you through doing the exercises, and it will also tell you how long you've squeezed and how strong you've squeezed. And so I think biofeedback is great, but I do sort of approach it with caution. I think for a woman who can identify her pelvic floor on her own, or who is working with a trainer to identify her pelvic floor, this doesn't give you very much added benefit. But if I have a patient who's been working on her own or with a trainer and is still having problems identifying their muscles, then I say, okay, maybe there's a rule for this, because it is a little bit more expensive technology. And then the NICE guidelines, which are like the USPF for the UK, they give lots of great guidelines when it comes to the pelvic floor. They're like a European governing body of doctors. they agree with that statement. They say really just use it for people who are having trouble identifying their muscles to squeeze, and not those who have a good squeeze to begin with when they first identify their muscles. And what about vaginal weighted cones? So you might have seen these advertised. They're small cones that you can insert into the vagina. Patients can wear them for 2 to 3 times a week for 10 to 15 minutes at a time. And studies show that they're actually equal in efficacy to physical therapy, and they're much better than doing nothing alone. So I actually use these for the patient who can't make it to physical therapy, who's having a hard time understanding how to do the exercises on her own. And this is a great adjunct, because if you can't make it to physical therapy or it's not covered by your insurance, usually these are relatively reasonable, and it's a way for them to just get an extra hand at identifying their muscles at home. So these are a really, really good tool, I think, for women who are struggling with kegels. And we live in a mobile and technologically advanced society. And I love this study. I think it's very well done and very smartly done. But physicians actually looked at all of the available applications there are for Kegel exercises out there in the internet, and they rated them based on how scientific they were, how easy usable they were, and if they had a doctor involved. And very few of the applications that exist out there actually contain accurate information on how to do Kegel exercises. This like blew my mind. I was like, how are these people developing apps that are not evidence-based? Very few cited the literature or were actually developed by a doctor or a physical therapist or a health expert. And you have to be very careful, because several actually disclosed that patient information from the app could be sold and saved to a third party. But the good news, after all that bad news, is that a few actually really stood out. There's an app called Kegel Trainer that came in sort of first place in this rating system. And there's several second place ones that I have listed on there. And there's both free and paid versions of most of them. So there are some winners. You just have to be very careful with the application you pick when you pick one. So what about vaginal inserts? So more and more women are asking for things that they can do on their own that are minimally invasive and have little risk. And so the world of vaginal inserts has exploded in the last few years. I mean, this has really changed in the last few years in my practice. So I'll first talk about the old tried and true. This was the only vaginal insert that we had for years, is the continence pessary. So you might recognize the word pessary. You might have had a friend that used one, or you might have heard of these. And they were made for prolapsed organs, when the organs fall into the vaginal canal or out of the vaginal canal. And someone years ago very smartly added this tiny little knob to the pessary made for prolapse. And that little knob sits below the urinary tube to block the outflow of urine. And so these have been around forever. There's very good studies to support their use. The biggest study in our field was called the Atlas trial. There was 400 women who had stress incontinence. They split them in half, and they gave half of them this pessary, and the other half they said, okay, just do behavioral therapies like Kegels. And they actually found that it worked about 50% of the time. And patients were very happy with the pessary, for using the pessary with their stress incontinence. Now, the one thing to know about a pessary is that you have to have it usually placed by a doctor, and there is some maintenance involved. It can stay in for 3 to 6 months. And then you have to see a physician to clean it, put it back in again. You can learn how to clean it yourself. I teach a lot of patients who like to manage it themselves. And if you're sexually active, you do have to take it out usually for intercourse. So some caveats there, but something that's pretty effective, 50% effective, and very, very safe to use. And here's a picture of how it sits in the vagina. So this is, can you guys see my pointer? Not if you can. Hopefully you can. So this is the uterus. Yeah, I see some nods there. Here's the uterus here. This is the bladder, and here's the pessary. You can see this knob portion sits pushing up against the bladder to block the outflow of urine and to prevent leakage when you cough or laugh or sneeze. So that's how it sits in the vagina. But really, over the last couple of years, there's been lots of innovation in this area. And now they're making over-the-counter inserts that you can put in the vagina that a woman doesn't even need to see a doctor. You can just say, hey, I think I have stress incontinence. I'm going to go to Amazon or CVS or Walgreens to buy these devices. I'm going to be able to put them in myself with very easy instructions. and that's going to help me with my leakage. So I love this. I love putting the power of some very safe treatments in the hands of patients. And so I'll talk about these devices. So this is the Revive. There was a nice study published not too long ago, 2021, of 50 women who put this insert in, and 71% of them had a reduction of leakage of greater than 50%. So that's not insignificant for something that you can do on your own. So you can see here, it has a tampon-like inserter, and then it opens up. It's this clear white sort of series of 2 rings, and it sits right below the bladder, putting a little pressure upwards and preventing the outflow of urine. There were some adverse events in the study. Mostly it was patient discomfort, some spotting with the device in, nothing very serious, still, approved for the use of stress incontinence. This is actually one of my favorite recommendations for patients. It's made by Poise, who makes pads. And so it's a company that women recognize and know, and I think there's a familiarity with that. This is a cotton insert, so it's a little bit softer and it's disposable. And it goes in like a tampon. You can see the tampon-like applicator. It opens up like a bow tie and sits right below the urinary tube to give it support. And in their study, they looked at 60 women, and 85% of patients had a greater than 70% reduction in their leakage when they used this device. I think this is great for the woman who plays tennis and leaks, who likes to go for a run and is worried about leaking on a run. It's because it's disposable, it can only stay in for 12 hours max. And so it's really supposed to be used for a day at max, and then you take it out. So for someone who's going to a comedy show, who's going to be around a family member where they know they're going to laugh and leak, this is a great option. And then there's more and more coming out in this area. So here at NYU, we actually we were the lead site investigating a new device that women will be eventually able to buy over the counter. I apologize, I don't have a picture of it because I made these slides when we were still going through the study. We weren't allowed to show what it looks like, but it will be bought over the counter. It will be self-insertable. And we finished enrollment, we finished the study, we're waiting on data analysis, and then the group will go to the FDA to look for approval for it. So this is coming down the pipeline, probably a couple months to a year away. But again, it's just to show that this is important for women. Companies are investing more money in it, and more research is being done in this area. So it's pretty exciting. I included this slide because probably by far and large, when I give talks to patients, large groups of patients about stress incontinence, I get a lot of questions about laser therapy. Everyone's asking about it because it's like one of the new treatment modalities that is coming to the market. And I wanted to actually show you a real advertisement that I pulled offline, and you can see this is for a specific type of laser. And here they're advertising that they're treating stress incontinence with their type of laser. And I just wanted to arm you guys with the information that actually laser therapy has not been shown to treat stress incontinence. And I think every time I see one of these advertisements, I sort of cringe because I feel like they're preying a little bit upon our patients who are desperate for some treatment for their stress incontinence. But this is a 2022 study that was published not too long ago that randomized people to laser or no treatment for stress incontinence, and it showed it didn't make a difference. And the American College of Obstetricians and Gynecology really says that there's not enough evidence at this moment to support the use of vaginal lasers for the treatment of urinary incontinence. So I think it's something really important for patients to know. These treatments are very expensive. They're not FDA approved. They're often out of pocket. And you'll see often companies advertising to patients directly that they do something that they really don't. So what about urethral bulking agents? We're sort of shifting gears and we're getting into more procedural and surgical treatments. And I really want everybody to know about these options because they're very effective. As we've sort of been going through this lecture and I've been talking about the different treatments, we're slowly inching and increasing in efficacy. You have physical therapy, which is about 50% effective. You have the vaginal inserts, which are like 60 to 70% effective. And then you've got urethral bulking agents that are more effective. They're in the more solid 70 range for efficacy. So as we're going on, we're getting more effective, but we're getting more into the procedural territory. And there's nothing wrong with that. Every woman sort of has different needs. So I want to make sure that everybody knows what the options are. So urethral bulking is really great. Urethral bulking, we take a small telescope. You can see this picture down here. We take a small telescope and we insert that into the urinary tube. We pass a needle through the telescope and we inject a filler, much like women get filler in the face. It's the same concept in the urethra. We inject a filler into the urethra to plump the tissue up and help create a seal. There are many different urethral bulking agents, and in the last sort of 5 years of practice, this has really changed. Our two oldest, or older, not the oldest, but the two older materials that I was very used to in residency in the beginning of fellowship was coapatite and macroplastique. And at the end of my fellowship in 2020, the FDA approved Bulkamid, which was a real game changer for my practice and a real game changer for my patients. And I'll talk a little bit about that in the next moment. There's a lot of advantages to this procedure. It's done usually in office. There are some people who will do it in the operating room. I don't use general anesthesia. I use local anesthesia with a numbing cream. And then I do a little lidocaine block around the urinary tube, much like a dentist would block a tooth. And there's very little downtime. I have patients who get this injection with me. They go right back to their work, doing what they're usually doing. The only thing I ask is no intercourse for 48 hours. But other than that, there's zero restrictions. So it's actually a very nice procedure for someone who wants something with very little downtime. So I have switched over to using Bulkamid as my main injecting agent. Like I said, it was FDA approved in 2022. 97.5% water and a 2.5% polyacrylamide gel, and there's a 60 to 70% satisfaction rate. So it's not as good as mid-urethral slings, which is a surgery I'll talk about in a little bit, but it's much better efficacy than some of the conservative stuff. So it sort of spans the middle. And I get this question all the time from women, well, how long does it last? The older injection agents used to last just a couple months. But we're really finding with Bulkamid, it has much better longevity. It lasts for much longer. 43% of patients may need a second injection after the first injection at 8 weeks. But once they get good with their injection, the 7-year outcome data shows that 67% are still very happy with their injection at 7 years. So most of the data is out of the United States as it got approved only in 2020. So 3 years ago doesn't go out to 7 years, but this has been used in Europe for much longer, especially Finland. And so that 7-year data comes from them. And we're really seeing in women who've had this for longer amounts of time, they're still pretty happy. So I think it's a great option for women. I see, can any of these treatments be used while in active treatment? What if you have cervical or vaginal cancer? That's a really great question. Cost and insurance coverage, yes. So to answer the first question about active treatment, anyone who's in active treatment, I speak with their oncologist about what's going on. And it depends on where they are in their active treatment. I usually don't do this in patients who are getting active radiation. But certainly with approval from the oncologist, if you're getting chemotherapy, it's something we can talk about and we can sort of stagger the procedure. And I've done this before, staggering the procedure based off, how they feel about your immunity and your white blood cell count. So yeah, some of these can be done. And certainly anything like a pessary or physical therapy is usually very safe for most treatments. So that's something that we can always employ pretty much all of the time. And I work a lot with GYN oncologists. I have many patients who we sort of go back and forth about optimal timing. So it's really important that the person treating this has an open discussion with your oncologist, whether it be GYN oncologist or other oncologists. Cost, that's a great question. So most of these are covered by insurance. Which is great. I had a little bit of trouble when Bulkamid first came on the market, having insurances understand that it was just a urethral bulking, but I haven't seen one of these get denied for insurance reasons for a very long time now. The one reason why a patient may have to pay more initially is if they haven't met their deductible for a year. That's one of the things in any procedure that you would do, but by and large, insurance companies are pretty much covering these, which is really great for our women. So great, yeah, keep the questions coming, but we're definitely also going to save some time at the end so that we can make sure everyone feels comfortable understanding what these are. Great. Okay, perfect. So now we're going to spend probably the next 10 minutes, 15 minutes talking about surgical options. So now we're moving into things that have much more efficacy, but also some risk associated, and we'll talk about what those risks are. It's interesting, the field of stress incontinence has really, really changed. And treating this 20 years ago was totally different than how we treat it now. The treatments that we had 20 years ago had a lot of risk associated with them, and they weren't super efficacious. And so with the advent of some of these newer surgeries, this has totally changed the game for our patients. So I think it's really nice to talk about. So these were the historic standard options. The first option was a pubo-vaginal sling. You would get an incision like a C-section incision. The surgeon would take a piece of tissue from your abdomen. They would make a little hammock out of that piece of tissue, and it would go beneath your urinary tube with a vaginal incision. And so it was nice because it was made out of your own tissue, but it had a higher complication rate and usually required an overnight stay in the hospital. And if anyone on this call has had abdominal surgery or a C-section surgery, it's a longer recovery. You have a abdominal incision, it's considered, you know, an abdominal surgery. So that was a tough sell for a lot of women who were busy and had things to do with their lives. And so yeah, that was a different time. And then the other one was a birch copal suspension, where you actually put stitches abdominally around the urinary tube and tack that up to a ligament that runs along the pubic bone. And this surgery was less effective than the ones that we have out now. It had a higher complication rate, and again, a longer recovery time. So that's historically the options that women had. But 20 years ago, in the early 1990s, a new gold standard came out called the mid-urethral sling. And so this is the most common surgery that we do now for stress incontinence. It's been around, again, like I said, since the 1990s. It's an outpatient procedure. You go into the hospital in the morning or the afternoon, and you leave a few hours later. It's a 45 minutes long, so it's a relatively quick surgery. I do it, me personally, I do it under general anesthesia. Mostly they allow my patients to have a little mask in the back of their throat that helps them breathe. Very rarely they will put a tube down a patient's throat as intubation. Some people do it while patients are awake. I just want my patients to be comfortable. And so I feel strongly about putting you know, anesthesia for my patients, but some doctors do it while patients have light sedation. And it's the most common procedure for stress incontinence that exists out there, hands down. Right now, if you were to go to a doctor who treats incontinence, they would say, this is the most common surgery that they do. And it does involve a permanent mesh implant, which we're going to spend a lot of time talking about because mesh is controversial, and you might have seen advertisements for it. And so I want to make sure everyone sort of gets the most up-to-date information on that. So how we put it in, we make a really small incision in the vagina, and we generally close that eventually with stitches that dissolve. You have small incisions above your pubic bone that are just covered with surgical glue. It's about the size of the tip of a ballpoint pen. We take a strip of mesh fabric and we place it below the urinary tube like a hammock. And it's a highly effective surgery. 80 to 90% of patients are satisfied at 1 year, 70% at 10 years. So it's got great satisfaction, great longevity. Most women only need one procedure their entire lifetime to help treat their stress incontinence. What are the recovery requirements, or what does recovery look like from a surgery like this? And really, since it's general anesthesia, a lot of the recovery is from general anesthesia. I tell patients to take a 10 to 14-day downtime from work just to be conservative and plan, but most patients are able to go back to work in 3 to 5 days. So most people are getting back to work sooner than that 10 to 14 day. I say to plan for the worst, and if it's better, that's great. 6 weeks, no intercourse, no tub baths, no swimming, no submerging in water, and the postoperative pain really should be pretty minimal. I send patients only home with Tylenol and Motrin. I think years ago, we used to send patients home with narcotics, and I've just found in practice that women weren't requiring them, and that Tylenol and Motrin would be enough to get them through and feel comfortable in the postoperative period. And what are the risks? Anytime you have surgery, there's always risks to surgery, and the risks to surgery in general are things like bleeding. The risk of bleeding from this procedure, having a major bleed requiring a blood transfusion, is less than 1%, so it's very low. Infection is always a risk, but I give patients infection or antibiotics before we do the procedure at the time when they get their IV placed. And then there's important risks to talk about, such as we're putting in a mesh implant. And so that's one of the major risks of this surgery that is unique to this surgery, but it's still pretty low, given that we're using an implant. So the risk of using the implant, you have a 5% risk that you might need an additional surgery to revise that implant. It's about a 3% risk that the little fibers of the mesh can become exposed. And if that happens, I usually give patients some cream that they can use to put over those fibers, and that helps the vaginal tissue grow over the area. If that cream doesn't work, then we can go back to the operating room in a second surgery. That's a very small 15 to 30-minute procedure where we cover the fiber with vaginal tissue and we close that with stitches over again. And then 2% of the time when we put the sling in, it works too well and women have some difficulty emptying their bladder. If that's the case, then we cut or we loosen the sling at about 6 weeks time. And we watch you and you come back and have a post-op visit at 2 weeks just to make sure that you're emptying your bladder well. But by and large, 5% needing to revise the sling is a very low number for this surgery. So what about the mesh that you heard in the news? And so we all, have seen these ads or these articles written about mesh, and the FDA actually put out a big warning halting the use of transvaginal mesh. And it's really important to know that the mesh for this surgery is not the same mesh that the FDA put out a warning about. And the FDA actually wrote that in their statement, but it's buried there in the paper. And so in 2011, the FDA had a safety communication saying that the mid-urethral sling is not the subject of this safety warning. And in 2013, they actually reissued a statement on their website very clearly stating that the safety and efficacy of slings is well established in clinical trials and is followed for patients up for 1 year. So the mesh that they're referring to is mesh for pelvic organ prolapse, where the uterus, the bladder, or the rectum are dropping down in the vagina, and it's not the mesh for mid-urethral slings. Patients who have these questions, I always spend some time talking to them, but there's a very good resource that the governing bodies in our field put out together. So that's OGS and SUFU. They put out this position statement. I just thought I'd take a couple seconds to show you the highlights so you could know what that position said. So the mesh is really polypropylene material, and it's used in many surgical specialties, things like general surgery, cardiovascular surgery, transplant, ophthalmology, and it's been used for over 5 decades. At the time that this position statement was put out, which is several years ago, so the number is likely much larger now, 3 million slings had been placed worldwide, and there were greater than 2,000 publications describing the safety and the treatment options of a sling that were very high scientific evidence and were peer reviewed. And so this statement sort of concludes that these slings have been very studied, they're very safe, and they're very effective relative to the other treatment options, and they really remain the gold standard for treating stress urinary incontinence. So that's all I have. We've got about 15 minutes, and I wanted to make sure I left some space for questions, as I know this can be a lot of information. It can be in a short amount of time. It can be very confusing. So I just want to make sure I save some space for that.
Well, first, I want to say thank you so much, Dr. Escobar. I think this was fantastic and so thorough.